Welcome to the Cook Medical Symposium at Virtual COSM 2021, I should say, Endoscopic Tympanoplasty. My name is Nicole LeBlanc, and I'm the Global Training Manager for Cook's Otolaryngology specialty. I want to say a special thank you to Dr. Ken Kazahaya, our distinguished speaker, for joining this session and leading us this morning. Dr. Kazahaya is Associate Director of Pediatric Otolaryngology at the Children's Hospital of Philadelphia, also known as CHOP, Associate Professor of Clinical Otolaryngology, Head and Neck Surgery at the University of Pennsylvania. And he's really been using endoscopes for surgery for over 15 years, and specifically been doing endoscopic tympanoplasty for about 8 years. Just a couple reminders before I pass things over. Reminder to keep muted unless you do want to unmute to ask a question. You can also use the chat box as well to ask questions, and I'll be keeping an eye on that and fielding them to Dr. Kazahaya. So without further ado, I will pass it over to you, Dr. Kazahaya.
Thank you, Nicole, and good morning, everyone. Thank you for joining so early in the morning for those of on the West Coast especially. I'm going to give a talk a little about endoscopic tympanoplasty, some tips and pearls, and also go over a few things with regards to the technique. But I'm gearing this mainly for those who are either new or starting out with their trying to do this procedure. We'll get started. And just as a disclosure, I am a consultant for Cook Medical. And so over the years, when we first started using these endoscopes, they really didn't give us a great vision, view of what we're looking at. It slowly improved over time. And then using, back in the 90s when we started doing endoscopic sinus surgery, it really got us in there, visualized, illuminated, but really still not great. But it wasn't until this century where we really got high definition video equipment, great telescopes, really been able to really look at detail. And that's kind of really where we started seeing a renewed interest in the use of endoscopes outside of the sinuses. And then, this really allows us to look at good definition of detail of anatomy and pathology. You can see things that you wouldn't have been able to see in the past. And that really helped open up the ability for us to use endoscopes in the ear. Now, the benefit of using endoscopes in the ear, one of the big benefits really is that you're not limited by the line of sight. So as we know in sinus surgery, you can see wide, deep inside because of that fisheye view you get with the end of the endoscope. Even with a 0-degree telescope, you can really see around corners. But then you add the angled scopes, and it gives you even more of the ability to visualize. So this is a little bit of an example. If you look at the pictures on the right there, the one on the left there, there's a view using a microscope looking at the eardrum, and then using a 0-degree endoscope, it's the same view, but you get in deeper, you can see a perforation that's around that anterior edge. Obviously, you wouldn't be able to work on that perforation through the microscope, but you definitely can do work on that perforation just using an endoscope. So you can really see where you need to go. You're not limited by the line of sight by the microscope. And then also, since you can see around corners, you don't need to actually take that anterior edge off, or you don't have to do extra dissections in order to get to certain areas. So it allows you to work on these disease processes a little easier and more expediently. So as I said, it does increase the ability to do things without really getting all overly invasive. For that anterior perforation, you usually have to make a posterior incision, come in from behind, or take that anterior canal wall down, and if you're using a microscope. But using the endoscopes, you don't need to do that. The other thing is, because you're not doing as much dissection and not much soft tissue work, you're not going to get as much swelling, so you don't have an ear that's going to be proptotic afterwards. They don't have as much pain. You can use endoscopes, and the angled ones especially, to look up into the antrum, and you can even get back to about the halfway part of the middle part of the horizontal canal using angled endoscopes, so you can reduce your need for doing mastoidectomies. Some of the other benefits, if you compare microscope to endoscope, one of the big things that really makes a big difference is the equipment cost. Microscopes obviously are extremely expensive. They're also not very portable. Endoscopes can be, depending upon how much you want to spend on them, and the video systems as well can be expensive, but with a relatively moderate budget, you can get yourself into doing these, and you can actually, it's transportable. So those people that have been using them sort of for medical missions and so forth, there's a few of our compatriots that use those devices in order to allow otologic surgery performed elsewhere where they may not necessarily have a microscope available. As I said, it gives you a wide field of view, and there's good looking around corners, and you can access using a very narrow portal. The endoscopes, typically the ones I'll use in the ear is the 3 millimeter diameter, 14 centimeter length. They come in multiple different sizes. There are other endoscopes available. The sinuscopes are actually 17 centimeters. You get long and unwieldy. So I typically don't recommend using them. Although if you want to start out and just try it, they're usually available, so you don't have to buy them especially. So you can actually do them. Sometimes the 14 centimeter length scopes are used for pediatric urology, so that there may be there in your hospital, and you may ask for them to see if you can try to use them or not. There are really short endoscopes that can be used for diagnostics in the office. They're about 6 centimeters. They're really not useful for operating with, because your hands are just right on top of each other, and you really can't use it well. You definitely need a high definition camera and video system in order to really be able to use these endoscopes. But it does improve in visualization. As once said, this is the picture from before around the edge of the anterior part of the canal here. You can see a nice perforation. It really gives you good detail of things you can see in the ear, retractions, and you can actually operate on them while you're there. Some of the limitations, if you do use smaller than 3 millimeters, they get really flimsy. They're easily torqued and broken. The ear canal size can be an issue, especially if you're on a really young child. But I have been able to do stuff even for a 1-year-old. I've been able to work on their ears using a 3 millimeter scope. But if the ear canal itself is really small, then you're going to be limited, and you're going to probably have to use a microscope. The blood in the ear could really, block your view, much like when you're doing sinus surgery. So you have to keep the tip of your scope clear. The vibrissae in the ear canal that is going to definitely get in your way can cause issues with your smearing of the end of your endoscope. So you want to trim those at the very beginning of your surgery. People try to use scope holders, additional assistance in order to get another hand in there, so that you're not limited to single-handed surgery. But most of the time I'm doing this single-handed, holding the endoscope with my other hand. Definitely there are companies working on different equipment for endoscopic ear surgery, because really, the curved instruments, suctions, everything, there are various adaptations that exist. Most of the stuff we use have been adapted from ear otologic instruments that we have and suctions that we've bent. So just talking about endoscopic tympanoplasty itself, typically you're going to prepare the ear canal well. You're going to irrigate, clean it out, inject with 1 to 100,000 or 1 to 50,000. There's different people that use various concoctions. Some use with or without local. And then what I usually do is place immediately a cottonoid in the ear canal that has a little 1 to 1,000 epinephrine. And I usually color it with a little fluorescein or methylene blue, just to make sure that nobody inadvertently suctions up, pulls up some of that in a syringe and you inject it inadvertently. It really helps prevent that. I've seen this happen in adult sinus surgery, and it's something I've always stuck in my mind ever since residency. You want to trim the ear canal hair. So once I put those cottonoids in the ear with the epinephrine, and then while I'm waiting for that to take effect, I literally take an iris scissor and I trim that ear hair, because it will make your life much easier, because it won't smear the end of your scope. And then I place the patient in a slight reverse Trendelenburg. When you make incisions in the canal, you can use various devices. I use a 7200 beaver blade. Other people use round knives, or there's some newer suction elevators you can utilize. We use this adapted suction which is basically a Lorik cone connector, a fish adapter, and a Bishop Harmon 19 gauge cannula. And this cannula actually comes bent like this, and it actually is like an ovoid end. So it's a nice sort of flattened tip, which you can use to suction and elevate your skin of your canal. You elevate your annulus. Once you've done that, once you've gotten in and elevated your annulus, a lot of the blood will then drop into your middle ear space and makes the dissections much easier. But until you get there, you're going to have to use suction and cottonoids or suction elevators to really get yourself in. Usually, when you're looking in the ear, you can use a 0 to 30 degree endoscopes. There are some individuals that say you should really start with a 0. Other people use 30s as their primary. It really, whenever you get used to, that's what you're going to use. But there are those that say use a 0 because it doesn't distort your angle or your view. So it's best to start with that. Also, when you're working on something in that anterior superior quadrant, because you're using endoscopes, you can actually consider changing your approach and maybe even making an incision more superiorly than inferiorly, or posteriorly, as most people do for tympanoplasties. Once you get in, you got to think, what am I going to use to repair my hole in the tympanic membrane? So you want the graft to be strong, flexible. You want a graft to be able to allow for tissue and vascular ingrowth, and it can't have a squamous portion. Other considerations for grafts is how easy is it to get the graft, the cost or relative cost of obtaining it. So how long does it take you to get like a cartilage graft or a temporalis fascia graft? You have to include that time it's going to take you to get that, and also to close it. But there's also a cost to using xenografts and allografts. So you all have to take these things into consideration. As far as autografts are concerned, people have used fascia, perichondrium, cartilage, composite grafts, fat. Xenografts, Biodesign, the autologic repair graft, is really the only xenograft that has been FDA cleared for use in tympanic membrane repair. Here's some of the examples of Biodesign autologic repair grafts. It comes in a nice little, some of them come in a nice little container with 2 different grafts. These are the little discs you can use for laryngoplasties. I typically use the 2.5 by 2.5 centimeter graft as my workhorse that I will use, and I'll cut the size that I need appropriately. You can use the 50 by 50 millimeter if you want to like line your mastoid cavity. It's sometimes nice to do that. Dr. Cohen out of Mass Eye and Ear back in 2016 published a study looking at endoscopic tympanoplasty and comparing it against non-endoscopic ear surgery, and looked at there's no real statistical difference in closure of the eardrum doing either endoscopic or non-endoscopic. He did note a slight improvement in pure tone audiologic outcomes using the endoscopic ear surgery versus non-endoscopic ear surgery. And there really was no difference in time early on in his use of this procedure. Biodesign autologic repair graft has been studied, and there's several publications on the success rate of closure of the perforations. Dr. Diardita published back in 2015 showing a 96% closure rate, and then there are various other ones later on showing similar late rates of closure. And these are very close and comparable to rates of closure from using temporalis fascia. Just this past year, Dr. Isaacson looked at using laryngoplasty, using gel film versus Biodesign autologic repair graft because gel film has been discontinued. He noted that it was a very similar closure rate using the Biodesign. So this is a nice presentation by Dr. Panetti out of Italy, looking at it's a video on his technique of doing endoscopic ear surgery, tympanoplasty. So he's got a perforation. He's rimmed the edge of the perf with the endoscope. He makes an incision using knife, and then he's going to elevate the ear canal skin. Tympanomeatal flap. He gets down to the annulus. He's using a suction elevator there. This is a cottonoid that's got a little bit of epinephrine to help with hemostasis. Here's in middle ear base, detaching the TM from the malleus because the hole was right up against the malleus itself. He also will utilize micro cup forceps to help do some of the dissection. It helps in order to grab and pull. You really get a nice clean removal and dissection off of the malleus there. And then he uses a piece of biodesign here. You can see it's going in the ear. It's a very nice graft to use. It doesn't, it's got a little stiffness to it so that you can actually maneuver it well. It doesn't, get all soft and squishy with like temporalis fascia can. It doesn't. It allows you to really manipulate it and use it, especially if you have trainees. It's particularly nice because they can work with it for a while and it really doesn't change its characteristics at all. It lays the tympanomeatal flap back, and you can see nice closure. Now, one of the key things there is you notice it's very flat in there. So you really want to make sure when you are using this graft that it really is flat up against the underside of your tympanomeatal flap. You don't want it to be bunched up or have a big crease in it. You're going to improve your closure rate by making sure that's really well opposed to the underside of your tympanomeatal flap when you're doing an underlay technique. And then he's going to fill the miliary space with gel foam as well to just support the graft. And he's going to return that back to his normal position. And he just removes this in order to show you how the graft looks with the gel foam underneath. It's well supported all the way around the entire perforation. And then he just packs with some gel foam there. And then this is some, haul before. And then this is about 15 days after surgery. You can see the graft starting to incorporate. And this is like 6 weeks later, and then you have even better incorporation. And then about 60 days, it's basically healed. And this is another thing you can do with endoscopes and I've ended biodesign, which is really nice, is something we do is a pull through. This is an anterior perforation. There's a big anterior overhang here, which would make it very difficult to do this with a microscope. You wouldn't be able to see this anterior edge of the perforation at all. And then what I do is I create a little tunnel in the anterior wall, coming down along the raised annulus here. And you got to make sure you raise the annulus all the way from above them to below the extent of your perforation. And then doing a standard posterior tympanomeatal approach incision, I get into the middle ear space, and I'll push a graft into the middle ear space that has a little tab that comes off the front of it. And then I can pull that tab up through that anterior tunnel. And then that will pull that graft up and seal it up against that anterior edge, avoiding it from dropping into the middle ear space. And then you get a nice closure of that perforation with using this technique. And you got to make sure you don't blunt that angle. So make sure that you do get gel foam right up against that anterior edge and annular edge. Otherwise, you're going to get some blunting. So some of the tips and pitfalls, I typically would recommend using 0-degree scopes to begin with. Try it on simple things after you've maybe used a material in the ear and then really gotten yourself used to using it. Now, simple tympanoplasty using a microscope, then you go over to an endoscope at the end to get yourself used to it. I use the 0-degree as a workhorse and only use the angles just so I don't risk any disorientation. There are those that do feel that the 30-degree is better for them depending upon the ear. Endoscopic ear surgery is not something you just drop into doing. It does show it has a steep learning curve. And then there are people that have shown that you got to do about 50 cases or so to really get your skills up and be able to do it effectively. Other thing really be important is not to overheat your ear. It's a small space, so you don't want to use an endoscope that has a xenon light source at 100%. You're going to burn the middle ear space and overheat it. You want to keep that xenon light source down below 50%. Now, the LED sources are not as hot, so you may be able to get a little bit higher. Fortunately, with some of these newer cameras as well, you can increase the brightness just by the sensitivity of the camera, so you don't necessarily need as much light. And then frequently moving the endoscope tip, irrigating the middle ear space, suctioning the middle ear space. These are all things to help keep the heat in the middle ear space down. You want to allow adequate time for your local to take effect. And once the ear canal skin is elevated, we do find that the bleeding typically isn't better. I use 1 to 1,000 epinephrine on small cottonoid pledgets. I don't typically use oxymetazoline because I find that the 1 to 1,000 works great. Yeah, obviously you got to watch out for the ossicles, and you need to really assess and clear that ventilation pathway in the middle of your space, which before using endoscopes was really not as well visualized, but now using them, you got to make sure that anterior and posterior isthmus are clear, and you want to make sure your tensor fold is open. So Marchione has some great illustrations of these ventilation pathways. We really want to make sure that the ventilation pathways to presac space as well as to the attic are cleared. And then here's behind another view that you want to make sure this space behind the ink is cleared of any synechia and to make sure the ventilation can occur. Tensor fold, various positions of it, and about 25% are arguably incomplete. If you're having ventilation issues, you want to make sure that this is not intact and you make a hole in it. So any questions?
All right, so we'll open it up for questions. If you feel so inclined, you can certainly unmute and ask your question. I'm also monitoring the chat box as well, so you can feel free to ask your questions there. So thank you.
Dr. Kazamaya. Oh, sorry, Nicole.
No, go ahead.
Doug Binion here from the University of Iowa. I appreciate your talk. Can you tell us a little bit about the positioning that you take in the OR? Do you stabilize your scope arm? Is there any time that there's a third hand that can be used for two-handed technique, or is it always just the one surgeon? Tips that would help us get started so that we keep good orientation and we have good stabilization on our case.
Sure. Yeah, for me, I typically like to just place my arms in a very natural position by my sides, and I use my sides of my body more to keep my arms relatively still. And I have the endoscope handled right about like a nice 90-degree bend in my arm, and I just use my hands in that position. I don't try to hold them out in front of me or in strange positions. You really want to make sure that the individual is well positioned on the table close to you and then come in. I typically have the head of bed just a little reverse Trendelenburg, and you can rotate the bed one way or the other if you want, just to make sure the ear canal is sort of in a good position for you to hold the endoscope. I typically make sure that your panel is really at eye level and just slightly angled away from you. Or toward you, so it's not flat up against you, because you get a glare otherwise. So you want to make sure that it's just a little bit, and you don't want to be straining your neck. So that's another reason why. Just make sure it's right in front of your eyes at a good level. We can use individuals to help with holding the scopes. There are individuals also that have tried using scope holders. The one problem with the scope holder is that it does lock your endoscope in one position. So if you need to get around it, or sometimes also in order to really get good depth perception, you need to be moving that tip of the scope up, back and forth. So I find that's a little limiting if you use a scope holder. But if you use another individual who is going to be able to move the scope in and out and around to where you need it to be, and is a good assistant, then you can do that. There are individuals that do use a second individual for that, but you don't always have that available to you as to help you with those cases. So if you want to just use it as a single surgeon, just make sure your arms are in a good, comfortable position. Usually that's enough to not have jittery in the scope. If you find yourself having issues with that, you can use like a Mayo stand to help hold your arm in a good position if you want to do that. There are some people that use these chairs that have arms on them, but I typically find you can bring just a Mayo stand in from the side or the other side, that contralateral side, and then you just put your elbow on it.
And there's a couple questions from the chat. So the first one is, where can you get the suction spatula?
Yeah, so it's an ophthalmic suction. So you can actually ask your eye group if they may even have it there already. It's like an irrigating tip that they use. So it's just a
I don't know why I can't load the volume. Sorry.
yeah, let me just get back to that one. It is the where was it? Yeah, it's a Bishop Harmon 19 gauge cannula, and it's an ophthalmic cannula. Yeah.
Okay, and another question from James Saunders. Great talk, Ken. I was wondering if you have any experience with using lasers with the endoscope. I've been doing this a bit and wondering if you have any tips.
Fortunately with the, I don't use it that often, but yeah, using a laser, especially with the waveguides, or even just you can use CO2 with the fiber, KTP with the fiber. It's very nice and easy to get the laser where you need it to go. But the nice thing with some of these lasers, especially the waveguides, it's self smoke evacuating, so it helps with the visualization. But I haven't used it too often, though. Yeah.
Are there any questions that someone wants to unmute for at this point? Okay, so I have another one. How do you think COVID-19 has impacted endoscopic tympanoplasty?
I don't know. I personally have not seen a big, other than the fact that I'm seeing some more advanced disease than I had, prior to COVID-19. I think there are people that are waiting to get ears worked on, and but other than the severity of disease I'm seeing, I don't necessarily see it impacting me in any particular way. Some people say they're not. It helps avoid drilling, so because there's a big concern of aerosolization with drilling. And so if you don't need to drill as much, then that's a benefit. So you can get into the mastoid antrum and the attic very easily using endoscopes to avoid you having to many times to have to do a post-auricular approach and drill the mastoid to get in there. So in a way that is a benefit. I use a irrigation that has 0.05% betadine in it. So for every liter of saline, I put in 5 mLs of 10% betadine, and that has the betadine has been shown to inactivate the SARS-CoV-2 virus. So if you want to use that as an irrigation, not only for your drilling, but you can use that just as your irrigation for the ear.
Perfect. And then from another chat, what is the composition of the biodesign graft? Is allergy a possibility? And do you specifically consent patients and inform them you are using a synthetic graft? That's from Ivan.
Yeah, so it's porcine derived. It's small intestine submucosa, and since it's an FDA cleared product to be used in the ear, I don't necessarily get a separate consent for that. I do inform them I will be using it, and those people that are either Jewish or Muslim, I do make note of that, and I say that it has been cleared or been at least approved by both of their sort of some of the clerics and the rabbis for use in those individuals.
Perfect. So we have time for one more question. If anyone wants to post it in the chat or come off mute.
Hello, I have
Go ahead.
this is Jim Saunders. I have a follow-up to that last question. So I know that some of the xenograft materials are prepped with gentamicin, specifically alloderm, and so I was always very cautious about using that in like stapedectomies. I'm just wondering, I haven't been able to find out if Biodesign if any of those ototoxic materials are ever used in the processing of Biodesign, and is it safe to use in a stapedectomy?
Oh, that one I'll have to look into. I don't know that offhand. Yeah. Yeah, but and it's interesting because alloderm is, yeah, people have used alloderm for different product uses, but it actually doesn't not actually has a clearance for particular use in the ear. They haven't made a specific clearance for that. Yeah.
So I'd had one bad experience with it, with using an alloderm as kind of a bridge graft after stapes that had hearing loss afterwards, and I don't know if it was the alloderm or it was just going to happen anyway, but. I just wasn't sure whether that was a concern with biopsy.
Yeah.
One thing I can confirm on my side, just from a Cook Medical perspective, the instructions for use do state that it can be used anywhere in the ear cavity, basically for various otologic procedures, including but not limited to tympanoplasty and laryngoplasty. So if you're talking about, being in the middle ear with the stapes, I don't see any kind of, clearance issues from the FDA at least. But we can look into that a little bit more.
Yeah.
Well, that's helpful. Thank you.
Question. Yeah.
Excellent. Well, that should conclude our time today. Thank you again for everyone joining. Thank you, Dr. Kazahaya, for leading us through today. Thank you to COSM for helping us set this up. It was excellent. And, have a great rest of your weekend.